So hello, my name is Cristina-Adriana Alexandru. I'm also from the University of Edinburgh in Scotland. And today I will make two short demonstrations of how to use the tool for different aspects. So I will start with assessing the maturity of healthcare systems using the tool. First of all, we recommend following this process, so consisting of 4 steps. In the first step, local organizers identify local experts to be involved in the assessment. Then the experts need to individually perform the assessment by using the tool. Then they share their individual assessments with the organizers. And finally, the organizers set up a workshop to discuss and reach consensus amongst the different experts about the maturity of their healthcare system. You can imagine that when selecting experts, you can end up with quite a multidisciplinary team, so people who have different levels of expertise and experience. Let's take an example where we would have a doctor, a nurse, an information technology specialist, and an administrator. Each of them needs to perform an individual assessment. For this purpose, they need to open a maturity assessment page on the tool, and this allows them to either fill in a form provided on the left-hand side here, or interact directly with a spider diagram on the right-hand side in order to enter a rating for each of the 12 dimensions. For each rating, they must also fill in a justification provided in the box underneath the rating scale. And finally, they need to save. You can imagine that because of their differences, each of the stakeholders in this example may end up with quite a different diagram, reflecting their own perspective of the maturity of their healthcare system. Before going further, they need to share their individual assessments with the organizers of the future workshop. To do this, as soon as they have saved the individual assessment, they have a share button that they can access and get to this share assessment page. Here they can use the text box at the end of the page in order to provide the email address of the organizers and just click share, which will add that email address to the table above to confirm that the organizers were, the assessment has been shared with the organizers, so the organizers can view it. When they are meeting in order to negotiate and reach consensus, the organizers can again use the tool. So they can go to the consensus, they can select the different individual assessments and click on compare and enter consensus, which would open up this consensus maturity assessment page. Here they can see on the spider diagram the different individual replies as underlaid, so represented in different color and put one on top of the other. And in the legend, the different colors are explained, and they can click on the different colors, on the different names of the different labels to open up the individual assessment if they want to. So this way they see how the points of views have differed. They can also see how the justifications of the different individuals have differed, which are represented above the justification box, again using the 4 different colors. To enter their consensus assessment, they again need to interact either with the form or directly with the diagram as they do for an individual assessment. And this time a black line will be created for representing each of their rankings. So let's say we had this overlay diagram when they first opened the page. You can see from here that not everybody agreed on all of the dimensions, on the ranking for all of the dimensions. In particular, if we take the example of standardization and simplification, we can see that somebody had selected a higher ranking of 3. It was the information technology specialist who explained in his justification, we are all using HL7 Fire. However, 2 other users, the doctor and the nurse, say yes, but getting the devices to interoperate is a nightmare. The administrator, however, thought that the rating should be somewhere in between. And he explains, this will all be resolved soon as we are joining an international standards group for devices. Through discussion during the meeting, they can decide that the IT specialist was too optimistic and the nurse and doctor were too pessimistic about the rating, and therefore go with the middle ground provided by the administrator. And they can record this decision by using the consensus form. As soon as they enter their decision, so such a discussion needs to happen for all of the dimensions where there wasn't initial consensus, and they will end up with a final consensus diagram represented with the black bar here. And this is just a short run through how a maturity assessment can be done using the Scirocco tool. Thank you very much.
Wow, That's how it's done. Okay, so I'm just going to very quickly invite our snapshot speakers up. So we're going to kick off with Igor, but if the rest of them could join us just up here and take your seats, please. So that's Igor, Lisbeth, Zdenek, Giovanni, and Margaret. And Igor, you can go up because you're first up. So just take a seat, thank you. So now that Cristina has given you an incredibly quick tour of the tool, what you're going to hear are also very, very quick. So this is going to be interesting because we are going to keep you to time. Yeah. Watch this space, Igor.
So okay, good morning, everyone.
Yeah. So what you're going to hear from each of our 5 presenters is a very quick overview of the health and social care organisation in their region. They're going to review their spider diagram, so the outcome of that exercise that Cristina took us through. And they'll identify the 3 key areas of strengths and weaknesses that they identified in their systems. So Igor, over to you.
Okay, good morning, everyone. Try to do it quicker than Cristina, which is very difficult. I'll try to. Anyway, just to follow the slides on that. Well, we come from the Basque Country. This is a tip of what Basque Country is in a way. 2 million people, more or less. 1/3 of the budget is located in the health system, universal healthcare coverage, and in order to health providers, we have 13 integrated care organizations, 2 subacute hospital, 3 mental health nets, and about around 30,000 professionals working in it. We started this process in 2010. So this is transforming the system into what is in there, the ICO, integrated care organization. Not that we were primary level and hospital level. We started that process, and we are all integrated care organizations today. The pillars are what you see in there: integrated, integrative governance, population approach, not just for disease, but the whole population is covered with these ICOs, and culture and new values in this new. So this was the process we have in order to assess with the tool. First, we have to get some of the stakeholders, local stakeholders, and these are the 10 people we found in there. We engage in the process. Some come from the Department of Health, which is the financer, which puts the money in the system. Some others are from the provider system, the Basque Health Service, in the upper level of the system, and some of them are clinicians. So those 10 people are covered in all those profiles. So the second one is, and this to me is quite important, is to introduce the project, to explain a bit what the project is all about, and particularly because of the wording, because of these new terminologies that sometimes are not clear. So this particular meeting was quite important. They went into the assessment process. They went to the tool, so the data collection, analysis with 10 spider diagrams, and then there was another meeting in order to discuss and get consensus with all these 10 people, and the summary of the results. So in order to see just the picture of how these profiles assess the process, the left one is the Department of Health, how that people saw in this case, the integrated care. The other one belongs to a ICO organization. And the third one comes from the social sector, which is not in the health service. There's another ministry. But so you can see some of the difference between among them. And at the end, when it comes to a consensus, these are the graph that appears in there, quite roundy, I would say. But some areas are not so good, like innovation in that sense, and also the finance and funding, which are probably the worst of the process. And some others, like a breadth of ambition and population approach, were quite highlighted. So at the end, just to key findings in the process, we said there's quite a more change. I would say the process is quite easy to do. These professionals those providers, they felt quite comfortable with the process. So probably there are some areas to develop, to improve, but as a starting point, they're quite I would say, quite happy with that, because it gives you the beginning of something with the same tool, with the same items and stuff. That's quite important in our thinking. Okay, that's all. Thank you very much. Very quick.
Wow. I think you've set the bar high there, Igor. That was 4 minutes. Well done. Okay, so that was our colleagues from the Basque Country. So next up we have Lisbeth Johansson from Norrbotten.
Hello, everyone. My name is Lisbeth Löper Johansson, and I'm the Director of Development in Region Norrbotten in Sweden. And we have 250,000 inhabitants in the region. And I will give you a short summary of the results from the self-assessment performed by the project group in Norrbotten. And I'm not an expert on Scirocco, but I have my expert in the room, so I feel calm. So, is it this one? Yeah. So. First, a brief introduction to integrated care in Norrbotten and Sweden. Chains of care and pathway of care as a model has been in focus in Sweden for more than 15 years. But we aren't experts otherwise, but we aren't expert yet. And based on the local agreement, this chains of care is based on local agreements between providers. And in Norrbotten, that means that we as a region with the primary responsibility for healthcare have agreements with every single one of our 14 municipalities. And right now, in focus in Sweden and in Norrbotten is to transform the system to be person-centered. And I think that's really, really important for integrated care. And now a short description about our project. We have been 9 participants in the local working group, and they were appointed by the local steering group and given the mandate to perform assessment. And they were chosen upon experience in integrated care from practical and academic perspectives, represent different levels and operations in the region, and with mandate to speak freely. And for example, it has been researchers, strategic officers, registered nurses, assistant director, community care, and business developers. And they have done the thing in 3 steps, in the process in 3 steps, as you have heard about before. The individual assessments, and here the example for 3 persons who have done their assessment. And then the stakeholder work group, and with consensus. And as Stuart said, I think that is the most important part of the process, because then you can reflect and then you can learn. And then the analysis of results, and it's still ongoing in Sweden. And here is our final consensus diagram. And the positive results you can see is on citizen empowerment. And I think in Sweden there are so many ways to getting support, advice, and getting in contact with healthcare 24/7. And every citizen in Sweden have access to their own e-health record. And we have a long tradition to work with patient organization and co-production. So I think that's why it's strong. And the weakness is evaluations after implementation, so we have to be better there. Thank you.
Excellent, thank you. Everybody really did listen to you. You're getting no more than 5 minutes, so thank you very much. So next up we have Zdeněk Guter from the Czech Republic. Now Zdeněk, you've got a little bit of leeway here, so we might give you 6 minutes.
Oh, thank you.
You have to
Keep clicking. Keep clicking.
Keep clicking.
Go.
Until you see your name.
I'm ready.
There we go.
Thank you. Good morning. First, I need to apologize to Mr. Petr Struk, who was unexpectedly called off for another meeting in the Czech Republic by the Vice Minister, so he couldn't come. And I represent University Hospital Olomouc, which was incidentally also one of the members of Scirocco. First, I will speak about the concept of integrated care, which actually in the Czech Republic does not exist. It is even not a political topic until, it was not topic until July 2018, when a new government was established, and integrated care in the Czech Republic is understood as coordination and interoperability of multiple healthcare providers and also social care providers. With the new government, there is ongoing reform of or preparation of reform of primary care, which is a big change over decades, and also what is important, that the shortcomings of current healthcare system are recognized, or are officially recognized, and consequently it was decided that integrated care strategy will be developed with help of structural funds, as it was spoken about by Mr. Domanski earlier today. This issue with non-existence of coordination of various players in healthcare is recognized by University Hospital Olomouc, which is a regional important healthcare provider in Olomouc region, and its task is to develop programs for particularly chronically ill patients, and with help of digital healthcare. So how it is organized in the Czech Republic in terms of integration. Integration is understood until today on the medical level. That means on the medical level there's quite good set of initiatives driven by the medical community, for example, care of cardiacs or cancer, and typically for this, all the initiatives are without ICT. That means usually via interworking on working level phones and papers until now. Then there are some rare integrated care initiatives by local authorities, usually using parallel financing model, which is the major issue with any changes, to find out a good financial model for any change. In Olomouc, we are developing good practices, and we are discussing with insurances and other stakeholders how to make them sustainable. This is our role in University Hospital. That means Czech National Health Centers is part of University Hospital in Olomouc. The healthcare system, I must say something before we come to the assessment, something about the system as such. It's Bismarckian, it's typical for the countries like Germany, Austria, and also Poland and Slovakia and Hungary. That means it was modified over the years, but important is that it's insurance-based system, and healthcare is separated from social care. The systems are developing for decades, for even century, independently, and we have fragmented healthcare providers with diverse ownerships, and there is no sharing data. That means no, there are no electronic health records that could be shared between various healthcare providers. And at the time, in late 2017, when we did the assessment of maturity for integrated care, there was absolutely nothing from e-health services spectrum. So the assessment was performed with 5 stakeholders who came to the meeting in the end. We used the methodology which was already presented during the conference, and the stakeholders were from health and social care sectors, strategists, and also academia professors. Okay. The result of assessment, it was reflected in the result that the long-term issues are really so strong that they give a result in zeros and ones. That means we know that the scale is from 0 to 5, and we have achieved scores like individual scores were sometimes even 2, but in the end we ended with zeros and ones. And that's why I need to speak about the context. That means the system is so resistive to any changes like integration that we could not achieve more than this kind of spider diagram. Okay, thank you.
Thank you, Zdenek. Okay, so next up we have Giovanni from the Puglia region. Thank you.
Okay, good morning everybody. The Scirocco experience is arisen in a southern region of Italy, Puglia, 4 million of inhabitants, 6 local health authorities, 2 university hospitals, and 2 research hospitals. We have 30 public hospitals and 29 private hospitals chartered with the regional health system. Like almost developed countries, we have a chronic problem, a chronic illness, a chronic disease illness. 4 citizens out 10 are on chronic conditions, and they spend 86% of healthcare expenditure. Healthcare system is mainly public in Puglia region. Another thing, besides hospitals, healthcare is provided through 49 health community districts distributed along the 6 local health authorities. Our assessment process, we involved 11 stakeholders distributed along 3 levels: macro level, meso level, and macro, meso, and micro level. I don't want to show to you all spider diagrams, but only 2, the most significant. This is the spider diagram of a regional manager, the offer, and this is the spider diagram of the demand, the citizen. And this is the real weakness, the wide distance between the 2 points of view. The overall result of spider diagrams, of the 11 spider diagrams, are these. And as I said, this is the real weakness, the actual weakness. Citizen empowerment, the wide distance among the 2 stakeholders. Which is, what are the lessons learned from outcome assessment? Scirocco, it was very useful for us to evaluate financial and regional endorsement to pilot experience. In the Puglia region, we have strong experience on integrated care, but they are local and pilot experience. not regional experience. So the tool, it was very useful to evaluate funding access to the experience to get to system, and to design our regional system model for integrated care, Care Puglia. I cannot describe by details these nice these nice tiny tools, but I like to show what are the pillars and the main features of our Care Puglia 3.0 for chronic condition. Profiling two organizational pillars, primary care clinic from one end and health community district on the other end. Strong engagement of a patient, only for GPs on integrated care unit, and so on. And this is an example of a shared plan for diabetes not complicated. The green box are the task with the telemedicine or teleassistance. That's all.
Thank you. Thank you very much, Giovanni. That was a whistle-stop tour, but a really interesting journey for you, I think. And we're just going to finish with our final region, which is Scotland. So we're coming home for some of us. And Dr. Margaret Worski.
Yeah. What did I do? Oh! We've got the video.
I think we were determined, weren't we, to get that. I'm not sure what happened there, Margaret. Right, if you just start, I'll just get it for you, sorry. We were doing so well, weren't we? We were almost there. Gosh, we'll be all our eyes will be going quite strange at this. Yeah, you could just do it really quickly, couldn't you? Right, we're nearly there. There's Norbotten flying past Puglia.
Here.
There we go.
And you just
I think you might have just
one.
pressed the wrong. So it's just this one.
the right one.
Yeah.
Good, okay, good almost afternoon, everybody, and I'm delighted to be here, obviously, to be involved in this final conference and sharing, I guess, our experience and where we'll go from here. So just quickly, Scotland has a population of about 5.5 million, and since 2016 we've had formal legislative health and social care integration. So prior to that, obviously there was a lot of encouragement and facilitation for health and social care to work in a more integrated way, but it was too optional. So our Cabinet Secretary and sort of policymakers sort of stressed the importance of actually setting health and social care integration into a legislative framework. So we still have 14 health boards and we have 32 local authorities, much bigger than your municipalities. But both the health boards and the local authorities devolve a whole range of services to our new integrated joint boards. So we've got 32 integrated joint boards across Scotland, varying size from about 20,000, where you go up to the islands in the northern part of Scotland, to Glasgow City, which is the biggest integrated joint board, a population of about 600,000. Importantly, the legislation requires joint governance, it requires joint budgets, and most importantly, it sets out a set of outcomes for citizens in terms of what needs to be achieved through integration. So we have a way to go, but we've got a framework and a governance structure in place. So we undertook the Scirocco assessment with 10 participants, reflecting people at a national level, policymakers from health and from local government, but also from some service providers in terms of the integrated joint boards, and also importantly our third sector providers. So our third sector providers in Scotland are our voluntary organisations, I mean not volunteers, but organisations who are not for profit, who provide a range of services to citizens and communities, and a key partner. And I should have stress that I think in doing the Scirocco assessment, we wanted to reflect that cross-sector, which has been referred to a number of times already this morning. So we know we still have challenges around integration within health, but we're really focusing on integration around the citizen and trying to ensure that the health and social care and other supports are integrated in terms of the citizen's experience. So you can see that we've got a bit of a range here in terms of the spider diagrams. Policymakers at this end are probably the, I don't know how to get my little light on. Anyway, your left. The more optimistic possibly in terms of the experience of the integration, and you can see the experience from our health and social care partnership in the middle. A bit more variable, although interestingly, it's the citizen empowerment one, I think that's got the strongest rating there, which was a bit surprising. And our third sector partners, our voluntary sector partners, a bit in the middle. So again, like some of the other speakers, you can see that we've got quite differences in terms of ratings. So some are a 4, for example, in policymaker, we've got a 4 on the structure and governance, and we've got a 1 from the health and social care partnership on that. And I think that does reflect that we have good enabling policy. We've got the right narrative around what we want to do. But yes, it is challenging and difficult to implement. And I think that's what this is demonstrating. It's not that people don't buy into the policy, but actually the reality on the ground is people are running to stand still with some of the demands of the health and care services. So in terms of what does that tell us about where we're at in Scotland? Well, I guess we have a number of strengths that came out from this as a readiness to change, that we do feel we've got that ambition and readiness. The structure and governance, while it was rated down with the Health and Social Care Partnership, I think when we got the consensus discussion going, I think there was a view that we do have the framework and we've got the governance in place to try and drive this through. And we've got breadth of ambition. So there is real ambition about we can do better. We can improve outcomes for people. We can make better use of our resources and get a better experience for our care and clinical professionals. On the weaknesses side, I think understandably there's an ongoing challenge around finance and funding. While there's been some additional funding provided for integration, again the reality is people are really challenged, I think, with the fiscal position and the increasing demand. We've also got a weakness identified through information and e-health services. Now, when I refer to e-health services, that's more about the infrastructure, systems, interoperability. We don't have citizen-held records. We've got a plan to do that. We've got challenges around different systems and different health boards that don't speak to each other. So again, I think that's reflecting the need to address that. And on a population approach, I think while we've got some good examples of a population approach, again, has come up through some of the presentations this morning, I think that whole focus on prevention, health inequalities and communities and how we really get that sort of built in to what we do, I think is still an area that we feel we've got more work to do. So thank you very much.
Thank you very much, Margaret. So Margaret's just going to come back. So we're just going to open the floor.